Good afternoon, everyone, or good morning. I'd like to talk about the challenges in diagnosing central disorders of hypersomnolence. I'm Kseniia Zub, I'm resident in Neurology and a research fellow in sleep medicine at Inselspital in Bern. On the research side, I'm particularly involved in the SPHINX study, the large international study you must have heard about. So, study on narcolepsy and its borderland. Within the study, we recruit patients with suspected disorder of hypersomnolence, as well as healthy controls, and investigate how the signs and symptoms change during several years. So it is quite often difficult and challenging to differentiate between the entities of hypersomnolence disorders, but it seems quite challenging also to identify and to confirm that the patient's main problem is sleepiness, so the problem to stay awake. Because patients often describe their symptoms in different ways, such as tiredness, such as sleepiness and tiredness, or tiredness with sleepiness, or unrestorative sleep, or lack of energy, or even concentration difficulties. To aid in differentiation, it can be useful to ask specific questions. For example, what would happen if, or what happens if, what happens in holidays, for instance, including what happens, for example, if you lay down and close your eyes, or what happens during your holidays, does it get better? Or more open questions such as in which situations does it get better, or in which situations is the sleepiness or tiredness worse? Patients might consider themselves as being just tired, but if they confirm that once they have laid down, once they have closed their eyes, they fall asleep. So this suggests more sleepiness and not just tiredness. Next, for example, if they confirm that short power nap is so after a short power nap they feel better, this also suggests sleepiness and not just tiredness. But of course, all aspects should be taken into consideration while putting the diagnosis. So different scales and different objective tests are widely used to provide some clues about the underlying pathology. This includes a very well-known Epworth sleepiness scale, or also multiple sleep latency tests, multiple wakefulness tests, actigraphy, etc. Nevertheless, the patient's complaint must be put in the very first place, and they should be the primary focus during differential diagnosis. There are indeed more unclear cases than clear ones. For the past year, we have been discussing the unclear cases, such unclear cases, during the case discussions organized by the Swiss Narcolepsy Network. Everyone is welcome to share their experiences and to bring their cases, to present their patients. In the SPHINX study, the diagnoses are given indeed, in fact, with varying degrees of certainty, which are definite, probable, and possible. Definite certainty is given in cases of narcolepsy with cataplexy or narcolepsy type 1, thanks to the established biomarkers. And in other cases, in most cases, the level of certainty remains probable or possible, and the diagnosis is reevaluated depending on the course of the disease, of the symptoms over the years. The SPHINX study has different dimensions and domains, such as clinical, electrophysiological data, digital data, wearable devices, microbiome, proteomics, epigenetics, and, for example, vigilance data. And the last one is what I'm looking at, what I'm particularly interested in. For example, in particular, how vigilance and attention are disturbed in narcolepsy and its borderland, how it correlates with other symptoms, with sleepiness, as well as with the results of electrophysiological tests, and how it changes depending on medications throughout the years. The first results of the Sphinx study have already been published, including the studies on wearable devices, on Fitbit device, and on the questionnaire and Swiss narcolepsy scale. Further results are coming up soon. We will keep you updated.